Okay, lovely. Always perfect.
Thank you, Norman. Thank you very much. Hi, everybody. Welcome to Congenital Heart Academy. We are very happy to have all of you with us today. This is going to be an amazing meeting. Very good experts to talk to you, and amazing Dr. Rima and Dr. Norman Silverman on the panel to discuss all of your questions. So please type all of your questions on a Q&A chat box. We are going to discuss in the end of the presentations. And I have a few announcements to share with you guys. So please follow us on social media and subscribe to our YouTube channel. Tomorrow we have Dr. Anderson with Dr. Silverman, of course, is always there, talking about the formation of the atrial chambers. This is going to be very nice. Please join us. And I just to remind you guys that we have a special edition of the Children's Journal coming in the next couple of months. So the end of the submission of manuscripts is going to be in May, 5th of May. So you have research in the congenital pediatric cardiology and cardiac surgery. Please send to this paper. Sasha is one of the guest editors. It's going to be a very special issue of the journal. I want to invite all of you to take a look in our YouTube channel. These were a meeting that we had last week. It was very interesting. I particularly learned a lot, even being part of the panel. We talked about what can we do today to our kids who went on surgery to make a better neurodevelopment for them in the future. So I think everybody should watch this webinar. It's in our YouTube channel. And it was very nice because it was a combination of Congenital Heart Academy, that is the official educational partner of the World Congress of Pediatric Cardiology and Cardiac Surgery. I can meet all of you there in August and September in Washington, D.C. If you want to scan this QR code, this is going to take you straight to the website WCPCCS 2023, and then you are going to be able to see all the information about the World Congress. And now with you, Dr. Rima is going to start this great meeting that we're going to have.
Hello, everyone. Welcome to our 22nd fetal webinar. We've been going on for 2 years, and I'm very, very happy with the feedback, and that a lot of people worldwide are listening and watching. I'm grateful to Congenital Heart Academy and to our great mentor, Dr. Silverman. Today, we have a great institution on board, and that is the Inova Children's Hospital in Virginia, and Inova Children's Heart Center in Virginia. And we should have had 3 great speakers from there, but the surgeon, I think, is stuck in the OR. We're going to start our first talk with Dr. Sarah Chambers. And Dr. Sarah is the current director of Fetal Heart Program, and she's going to talk to us about a very interesting topic. Sarah, could you please start?
Hi, everyone. I'm Sarah Chambers-Gerson. I am previously the Director of Non-Invasive Imaging for Inova Children's, and I am taking over the Fetal Heart Program, which is kind of where my passion has always been, as Kareem is unfortunately leaving us, and Lori Children's is lucky enough to be getting him as a colleague. And I'm very excited to hopefully see many of you at the World Congress later this year here in the DC area. So if you see me there, definitely say hi, grab me and introduce yourself. I'm going to share my screen right now. And here we go. All right. Can you guys see this?
Yeah.
Okay, great.
Yeah.
So one caveat too, thank you so much, Rima and all the organizers for inviting me to speak today. I unfortunately will not be able to stay on for the entire presentation. I'm glad I was able to do this as Lucas is stuck in the OR as well. I am at home with a 20-month-old toddler with COVID, and my husband was good enough to come home and spell me for a little while, so he rearranged work. But I will probably have to jump off before the full conclusion of this, the whole panel. But thank you so much, and I'm very glad that I could be here to participate in this today. So systemic venous abnormalities in the fetus, just talking a little bit about, when they occur and what we need to think about. They are rare in isolation, and they occur in increased frequency in association with other congenital heart disease. The persistent left SVC is the most common systemic venous anomaly that we see prenatally and postnatally. It occurs in 0.3 to 0.5% of the general population. However, if you look at patients with congenital heart disease, it can be in 2 to 10% of those patients, depending on what series you look at. And over 70% of patients with heterotaxy. And I'm not going to talk very much about heterotaxy because that is what Kareem is going to be giving us lots more information about. But you do have to think seriously about that if you see a persistent left SVC. In terms of the physiology, so many of these are not of at least immediate hemodynamic significance. So for example, we have persistent left SVC to the coronary sinus. If the coronary sinus is normal and drains to the right atrium from a hemodynamic standpoint, you still have a full return of the systemic venous drainage to the right atrium. You have the dilated coronary sinus, which we will talk a little bit about. Even if there's actually atresia of the right superior vena cava, at least initially, there's not a hemodynamic or clinical significance to that if the coronary sinus is normal and unobstructed. If you have an interrupted IVC with azygous or hemiazygous continuation, again, you have all drainage from the lower half of the body, the systemic venous drainage, still back to the right atrium via the SVC or LSVC connection. And so again, from a hemodynamic standpoint, it doesn't really change the blood. Retroaortic innominate vein, again, the connection's all normal, just the location is different, and in fetal life generally would not cause that much concern. And even anomalous hepatic veins to the coronary sinus, which is much more rare, from a hemodynamic standpoint, all the systemic venous return still comes back to the right heart. However, even these abnormalities that do not have any immediate clinical significance can have important implications later in life. So for example, if any of these patients need a cardiac catheterization or cardiopulmonary bypass procedures, those use systemic veins for vascular access. It is extremely important for going on cardiopulmonary bypass, as if left SVC is unrecognized, depending on whether there's a connecting vein especially, but even if there is, the ability to visualize.
Sarah, if I may interrupt, I mean, I wonder if, is everyone seeing, I'm stuck with one slide.
Oh, no.
No, you're stuck. You need to reboot and get on again.
Okay, so everyone is watching.
Everyone else can see?
Perfectly.
Yeah, very well.
Okay,
Perfect.
thank you.
Okay.
Thank you.
Thanks, Norm. Sorry, Rima.
No, it's fine. Thank you.
Okay, so left SVC, if it's unknown before cardiopulmonary bypass, the surgeons have significant difficulty in visualizing the surgical field and truly emptying the heart. Additionally, for cardiac catheterization, especially in babies, many of those procedures would tend to use the femoral vein for the venous access. And of course, if an interrupted IVC is unrecognized, that is not going to be able to access the right atrium and the rest of the heart. And it can make certain procedures extremely technically difficult or even impossible. Additionally, babies born premature or who have other complex congenital heart disease. So first of all, many of them will need cardiac cath or cardiopulmonary bypass procedures, but also many get umbilical venous lines placed. And so an interrupted IVC can also affect that. Single ventricle patients. So as we know, surgical palliation for these patients attains passive drainage of the systemic venous return to the pulmonary arteries. And the stage 2 procedure, or the Glenn procedure, requires bilateral cavopulmonary anastomoses if there are bilateral SVCs. And again, if a left SVC is not recognized, especially if there is an absence of a connecting vein between the two, you're going to have much more cyanosis after the Glenn if the left SVC is still connected to the heart. Additionally, as we talked about, many of these patients have heterotaxy, which again, Karim will talk about, but heart block in some patients with heterotaxy is a significant risk. And placement of an emergency pacemaker will often require accessing the systemic veins. So again, knowing if there is anomalies of any of these veins can be clinically very important postnatally, even if they may not be of immediate hemodynamic significance. All right, so when do systemic venous anomalies matter even more from a hemodynamic standpoint? So persistent left SVC, if there's an unroofed coronary sinus or a direct connection to the left atrium, that desaturated blood is going to be able to drain into the left atrium, and you're going to have decrease in your oxygen saturations. Coronary sinus ostium atresia or stenosis in the presence of a left superior vena cava, or even just isolated without a left superior vena cava, can be very significant from a clinical standpoint. So the thought is that generally coronary sinus ostium atresia or stenosis happens from a prominent Thebesian vein, occluding the ostium. If the coronary sinus is unroofed, if there is an LSVC that's present, you can see decompression of the coronary sinus. Sometimes it actually decompresses through the Thebesian vein as well. But knowing that the coronary sinus ostium is either atretic or stenosis is extremely important later in life. And if there is an LSVC, it is an absolute contraindication to ligation of the LSVC. So in patients in whom you are ligating the left SVC, making sure you visualize the coronary sinus ostium well and exclude atresia or stenosis is extremely important. And the reason that there's the risk of MI is that you don't have that drainage of the coronary venous flow into the coronary sinus and back to the left atrium. And that affects ability to continue coronary perfusion. A levoatrial cardinal vein. So these are different than a left SVC. We'll talk about them a little bit when we talk more about left SVCs. but these are generally a pop-off. It's a residual embryonic venous connection that serves as a pop-off to decompress the left atrium in the setting of left atrial obstruction. It courses posterior to the left pulmonary artery as opposed to the left SVC, which courses anterior to the left pulmonary artery in general. So it courses behind the left pulmonary artery and anterior to the left bronchus. And this often constitutes an anatomic vice and can get obstructed. So in patients in whom you're following that have a levoatrial cardinal vein, if the levoatrial cardinal vein is clinically relevant to decompress the left atrium, you need to make sure that there's no obstruction to that decompressing flow as it courses superiorly through the thorax to drain back into the systemic, the other systemic veins. And then an interrupted IVC and a single ventricle palliation. So as we talked about, the stage 2 of the single ventricle palliation is the Glenn procedure, or the cavopulmonary anastomosis, when the superior vena cava is connected directly into the pulmonary arteries. And if you have an interrupted IVC with azygous or hemiazygous continuation up to the SVC or the LSVC, all of your superior vena cava and inferior vena cava flow is going to be directed into the pulmonary arteries during the stage 2 procedure, leaving only the hepatic veins connected to the heart. This results in a much bigger volume shift related to the stage 2 procedure, and is important to be aware of because it can affect both your initial recovery and transition to that to the new circulation. And also, we'll talk about a little bit more later, but the hepatic factor that comes through the liver is still not connected to the lungs in these patients. So that was a lot of talk about clinical significance, but still mostly related to postnatal diagnosis. Do systemic venous anomalies ever affect the prenatal course? So persistent left superior vena cava to a dilated coronary sinus has been associated in some patients with the development of small left-sided structures. Now, this is mostly only case reported. From an anecdotal standpoint, I have definitely seen it multiple times where there's a big dilated left superior vena cava, and over time, especially during fetal development, there's concern for mitral valve development or aortic valve development. Sometimes even coarctation has been reported. And the question is whether or not the dilated coronary sinus could actually be affecting the flow through the right atrium and through the left heart, and therefore affecting growth. Absent ductus venosus. So this is something we are going to talk about related to fetal hemodynamics. And the absent ductus venosus, the hemodynamic significance really comes from whether there's an intrahepatic or an extrahepatic connection of that umbilical venous return, finding a different place to drain to. Persistent right umbilical vein is something that is diagnosed in the fetus from a hemodynamic standpoint. Most of the time it does not affect the fetus, but it does raise question of association with other anomalies. So it's something that is important in fetal diagnosis to raise or lower your threshold to search for other anomalies. And this is just, we're not going to talk too much about a persistent right umbilical vein. The left umbilical vein is usually the one that drains the umbilical venous return back to the ductus venosus and then to the fetal heart. If there's a persistent right umbilical vein, you see this curving towards the right, towards the stomach on the transverse abdominal view. It can connect still to a ductus venosus, in which case the restrictor aspect of the ductus venosus flow is still there. If it drains somewhere else, especially if it drains directly into the systemic venous circulation, like directly to the IVC, that would be a hemodynamic problem and concern. But that is much more rare in persistent right umbilical vein. All right, so in terms of specific focus for this talk, from a fetal cardiology standpoint, We're going to focus more on mostly on the left superior vena cava, the interrupted IVC, and the absent ductus venosus. There are lots of other systemic venous abnormalities that can exist, including abnormalities of the hepatic veins, of the coronary sinus, of the innominate vein. Leo Lopez and I have a chapter in Wyman Lai's echo textbook that goes through some of them in more detail. And other echo textbooks and fetal echo textbooks also have excellent descriptions of some of those other anomalies. But for the purposes of this talk, this is what we're going to focus on today. So understanding systemic venous anomalies, how they develop and what you should look for, we have to go back to embryology. This is a picture of Leo's cat in front of his embryology textbook. And at least when I was in medical school, this was often how I felt in my embryology lectures. However, as I've kind of grown up in fetal cardiology, it really is extremely important for understanding and being able to evaluate so much of what we do in fetal and pediatric cardiology. And definitely in the anatomy of abnormalities in the fetal heart. So this is from Netter's textbook, just looking at the systemic venous return. I'm not going to go too much into the embryology now. When these slides are available, I have a bunch of information in here that we're not going to spend too much time on today, but people are free to peruse those at your leisure. This diagram is just really nice at explaining that the systemic venous anatomy really comes from multiple different portions of embryonic venous development. These different colors represent different origins of the systemic veins. And looking at this, it looks like a rainbow, right? There's lots of different pieces to this process in terms of development. And therefore, there are lots of different points at which the process can become interrupted or develop abnormally. So there are three basic venous systems in the human embryo: the cardinal veins and the tributaries, which ultimately form the SVC and IVC systems; the umbilical, vitelline, and omphalomesenteric veins, which carry blood from the placenta and the yolk sac and the intestine; and then the pulmonary veins, which obviously return blood from the lungs to the heart. This is the piece we're not going to go through very much, but the umbilical veins develop first, then the vitelline veins, the sinus venosus, which is the cavity into which all veins eventually drain, connecting to the heart. The sinus venosus shifts rightwards, then the cardinal veins start to form. The vitelline veins become the hepatic sinusoids. The left umbilical vein gains dominance. And then you have gradual formation of the portions of the IVC, the ductus venosus, and the SVC, and full formation of the IVC with all the different components of the IVC. Again, we're not going to go into this in too much detail, but just recognizing that understanding this really does help us to visualize and evaluate abnormalities of the systemic veins. All right, so to summarize, the right SVC comes from the right anterior and common cardinal veins. And when you have a left SVC, it means there's been persistence of the left anterior and common cardinal veins, which usually regress. The innominate vein forms from a connection between the right and left anterior cardinals. The coronary sinus is formed by the left common cardinal vein and the left sinus horn. The IVC is probably the most complex. The suprahepatic portion comes from the vitelline veins, the hepatic and the renal portions from the subcardinal veins, and this is an extremely common site of interruption. We'll talk about this a little bit later, but any of you listening who have been in the echo lab with me as we're evaluating the IVC know that it's extremely important to show the IVC to the level of the kidneys, as if you do that, you evaluate this most common site of interruption of the IVC. And then the infrarenal portions are formed from the right supracardinal veins. The azygous system, the azygous is from the right supracardinal veins as well, and then the hemiazygous would be from the left supracardinals. All right, so back to what we're focusing on this talk. I promised we would not do too much embryology. the left persistent superior vena cava. As we said, this is the most common anomaly of systemic venous return. 2 to 10% of patients with congenital heart disease will have this. And then in certain lesions, tetralogy of Fallot and AV canal, it can be up to 10 to 20% of patients. It is extremely common in heterotaxy, most dominant in asplenia, where more than 70% of the patients with right atrial isomerism could have a left superior vena cava, but a significant portion of patients with polysplenia or left atrial isomerism will also have a persistent left superior vena cava. So from an embryologic standpoint, the left anterior and left common cardinal veins do not regress. The left superior vena cava will course generally anterior to the left pulmonary artery between the left atrial appendage and the left pulmonary veins. The majority of them connect to the coronary sinus, and slightly more than half, about 60% of them, will have a connecting vein, which is essentially what would become the innominate vein, but a connecting vein that connects the two. And that can be a very variable size. They can be small or they can be really quite large. In terms of the fetal diagnosis of a left superior vena cava, I have found that often these patients are referred for a possible atrial septal defect. The dilated coronary sinus can look very like a primum ASD in the 4-chamber view. And so anytime I get a referral for this, especially if someone thinks maybe there's a variant of an AV canal where you don't have a large or even have no ventricular component and you just have an isolated primum ASD, my red flag immediately goes up in my head in terms of, could this be a dilated coronary sinus with a persistent left SVC? The coronary sinus is posterior on the left atrium, and small sweeps through the 4-chamber view to determine whether the defect that looks like it's connecting the left atrium to the right atrium is posterior in the left atrium or not, can be very helpful. In terms of some diagnostic pearls, so as 92% of the persistent left superior vena cava connect to the coronary sinus is generally dilated. So anytime you see a dilated coronary sinus, you've got to think about this. It's not the only thing that can cause dilation of the coronary sinus, but it is probably the most common. The 3-vessel view becomes a 4-vessel view if the right superior vena cava is still present, which generally it is. And so paying close attention to the leftward aspect of your 3-vessel view is also important. So what should I be thinking about if I'm looking at a fetal echo and I'm thinking I see a left superior vena cava? So I do always look at the adequacy of left-sided structures. In general, in fetal cardiology, right, we say you need flow to grow. And so if the coronary sinus is so big, it's always that it changes the flow dynamics through the left atrium. It does seem like it would be possible that the left-sided structures could be affected. And like I said, there are case reports and I have seen multiple patients who have a dilated left SVC and small left-sided structures. Whether those are actually just associated versus causal is unclear, but I always look very closely at the left-sided structures. You can have a left SVC directly to the left atrium as opposed to the coronary sinus. So this occurs in about 8% of patients with left superior vena cava. The left SVC goes directly to the left atrium after birth. If the PFO closes and you have no connecting vein, these babies will have lower oxygen saturation and will not be fully saturated because that deoxygenated left SVC flow will go directly into the left atrium. Now, they may not fully appear cyanotic from a clinical standpoint. Their saturations may be 90 or 92%, but it will be lower than normal. If the PFO closes and a connecting vein is present, the left SVC decompresses the left atrium and you'll get retrograde flow up through the thorax to the right, to the innominate or the connecting vein, and then to the right SVC in the RA. And in this situation, it acts like a left to right shunt, so similar to a large ASD or partial anomalous pulmonary venous return. And if you have enough left to right shunting over time, surgical repair can be indicated, just like in a large ASD or partial veins. And remember, in any left SVC, not so much in this one, but remember in any left SVC to the coronary sinus, you want to make sure you get a good look at the os of the coronary sinus as well. When an LSVC is not an LSVC. So we talked a little bit about levoatrial cardinal veins earlier, the embryologic connection between the capillary plexus of the embryonic foregut, the origin of the pulmonary veins, and the cardinal venous system. If you have elevated left atrial pressures early in gestation related to left atrial obstruction, this vein may persist to decompress the left atrium. Mitral stenosis or atresia, with restriction of flow across the PFO or atrial septum, or obstructed total veins are examples of this. Again, it courses posterior to the left pulmonary artery. So visualizing the course in the transverse plane can be important. So sorry, I don't know why this isn't looping, but here we just have a image of a transverse plane of the fetal heart. This is posterior and anterior, left and right. Here we have the right atrium, right ventricle, left atrium, left ventricle. And here at the leftward aspect of the left atrium, we see this big circle that we don't usually see. And that is the dilated coronary sinus. And if we rotated our probe just slightly posteriorly, we would see that become linear and course along the back of the left atrium into the right atrium through the os of the coronary sinus, which would be right here. From the 3-vessel view, we talked about when the 3-vessel view becomes a 4-vessel view. So here, this is again a transverse view of the fetal thorax. This is the spine posteriorly. This is anterior, left, and right. And this is the main pulmonary artery coming out and heading with the ductus arteriosus. We'll head back towards the descending aorta. This is the ascending aorta. We don't see the right SVC perfectly, but that's over here. So this would usually be your 1, 2, 3 vessels. And we see this other circle right here to the leftward aspect, and that's going to represent your persistent left superior vena cava. This is just another both diagram of it as well as an annotated picture this time. So here's your normal 3-vessel view with your right SVC, aorta, and pulmonary artery, the left aortic arch coursing from right to left, anterior to the trachea. And then on the leftward aspect, we see this other circle, which represents the left superior vena cava. From a sagittal plane, you can see, so this, and it's very zoomed up, I apologize, but this is a sagittal view through the fetus. The baby's head would be up here, feet would be down here. Here's the left atrium posteriorly, and then behind that, you can see the left superior vena cava as it courses caudally in the thorax and joins the coronary sinus, which runs inferiorly in the left atrium from left to right and would drain into the right atrium. And if you get different views that are kind of the fetal equivalents of the parasternal long and short, you can often show this in a few different planes in the fetal heart. All right, so moving on to talk about interrupted IVC. So it is exactly what it sounds like. The IVC, instead of coming up and connecting directly to the right atrium, does not connect directly to the right atrium, and instead that blood that's come from the lower half of the body finds an alternate way, generally the azygos or the hemiazygos, up to the superior vena cava. So again, not going to go into embryology too much, but multiple different venous systems have to come together to form the IVC. And if that hepatic segment is missing, you do not get the connection of the IVC to the right atrium. So you have failure of the right subcardinal vein to connect to the right vitelline and the right hepatocardiac veins, resulting in the absence of this segment. Generally, the right superior supracardinal vein will enlarge and become the azygos continuation to the right SVC. If it's a left SVC that you have, the left supracardinal vein will enlarge. Occasionally, the drainage is more unusual. So there are case reports, for example, of a hemiazygos connecting to an accessory hemiazygos connecting to the superior intercostal veins and then to the brachiocephalic veins. But most of the time, you're going to have an azygos or a hemiazygos continuation. The hepatic veins do maintain their connection to the floor of the right atrium, and that's important to remember. So you are going to see some veins draining to the right atrium on fetal echo and postnatal echo. And some of those hepatic veins can be quite big. So understanding the anatomic course of the IVC and what's required to be sure that that's what you're visualizing is really important. So an interrupted IVC occurs in less than 0.3% of people with no other forms of no other associated congenital heart disease. So it's quite rare in isolation. It occurs in 0.6% of patients with congenital heart disease in general, but it occurs in up to 84% of patients with left atrial isomerism, especially polysplenia. It is rare, but has been reported in patients with right atrial isomerism. So the clinical significance of an interrupted IVC, so again, most often seen in the presence of heterotaxy. If you are suspicious for an interrupted IVC, you really have to look for associated cardiac anomalies, as it is quite rare by itself. And then its hemodynamic significance is determined by the associated cardiac anomalies. So for example, if you have an anomaly that requires planning for cardiac catheterization or cardiopulmonary bypass, knowing that the IVC is interrupted is essential. Left atrial isomerism, which we saw is, it can be in 84% of these patients. Those patients also have an increased risk of complete heart block. So emergency placement of a pacemaker often requires systemic venous access, and knowing about any systemic venous anomalies would be, again, very important. And single ventricle palliation. So like we talked about, the stage 2 procedure connects the superior vena cava or cavae to the pulmonary veins, and all systemic veins except the hepatic venous connections would be directed into the pulmonary arteries if you have the interrupted IVC. So the hepatic vector would still be bypassing the lungs. It would be still going back to the heart, and as we know, that's important for lung vascular development. So that's still not directed in there in the Kawashima procedure, but the volume load of that heart is very different. And so you're directing a much bigger volume into the pulmonary arteries. Your changes from a loading standpoint of your heart are very different, and it can affect your recovery from that as well. All right, so diagnosis of an interrupted IVC by fetal echo. As we said, you have, an absent hepatic segment. So the interruption occurs just above the renal segment. So again, we need to show the IVCs the level of the kidneys. And if you don't, you can mistake a prominent hepatic vein for the IVC. Now in the fetus, when we have this lovely sagittal view of the fetus here, here's the spine posteriorly, this is anterior. Baby's head is up here and baby's feet are down here. We can get this beautiful bicaval view even more clearly in a fetus than we are able to see in many postnatal patients. You see the SVC coming down, connecting to the right atrium, and this is the IVC connecting to the right atrium as well. So this is not interrupted. You want to, again, make sure you show it to and ideally past the level of the kidneys. And you do also see that the IVC kind of takes this posterior course. Another great pearl that one of my colleagues has said before, which is a great kind of thing to think about, is in general, you see the IVC and SVC, this beautiful bicaval view, when you're in the same plane as the aortic arch. If you are seeing the ductal arch, that tends to be the view in which you see the ductus venosus the most easily. That's the plane in which you see the ductus venosus. And so if you're thinking you see the IVC, but you're in the plane of the ductus arteriosus as opposed to the plane of the aortic arch, you again would really want to prove to yourself that that's truly the IVC that you're seeing and not a prominent hepatic vein. So this is a video clip of a sagittal view of the fetus, kind of parasagittal. The head's up here, the feet are down here. You see a portion of the aortic arch here with the brachiocephalic vessels arising from it. And you see some veins kind of from the liver and abdomen that appear to be connecting to the right atrium. But even when you see the right SVC connecting to the right atrium, you don't see that beautiful connection of the IVC to the right atrium. All right, so that was interrupted IVC, and we're gonna move along to absent ductus venosus. So this is something that is more relevant in the fetal and generally less relevant postnatally. As we know, the ductus venosus carries oxygenated blood from the placenta to the umbilical vein. Well, the placenta goes to the umbilical vein. The ductus venosus carries that blood from the umbilical vein to the heart, bypassing the fetal liver and acting as a restrictor to the flow returning to the fetal heart from the placenta. Absent ductus venosus has been reported as anywhere from 1 in 500 to 1 in 2,500 pregnancies, either being completely absent or draining to an atypical site. In general, it's absent, and then the umbilical vein is what drains to an atypical site. The biggest factor to think about when you are concerned about absent ductus venosus in the fetus is whether the drainage is intrahepatic versus extrahepatic. So when a ductus venosus is absent and the umbilical vein drains via intrahepatic routes, essentially the intrahepatic or the umbilical vein finds other connections within the hepatic vasculature, and you tend to have restrictive flow just like you do if the ductus venosus is actually present. However, if it's extrahepatic connection of this umbilical venous flow, the umbilical vein can drain directly into the IVC, for example, or directly into the right atrium. And if that's the case, there is no restrictor to that flow in general. And so you can have a high volume load to the heart, and those are the patients with absent ductus venosus who can get very sick. Absent ductus venosus does increase the risk of other fetal defects, including other cardiac defects, as well as genetic defects. So a thorough fetal echocardiogram to look for other associated cardiac lesions, as well as genetics counseling and recommendation for genetic testing, either prenatally or postnatally, if the family does not pursue fetal testing of genetics is recommended. So historically, ductus venosus has been recognized for a long time, centuries, and historically it was thought to have an extremely poor outcome. And this was because the patients in whom it was recognized and diagnosed were those who had the extrahepatic connections. And so again, they had high volume umbilical venous return to the heart. They can develop high output heart failure, hydrops fetalis, and intrauterine fetal demise. In more recent years, as our fetal echo technology has improved significantly, our fetal ultrasound technology, I should say, it has been realized that the intrahepatic connection does occur. And I'm sorry, this I didn't complete the sentence for some reason. The hepatic vessels, as we discussed before, act as a restrictor. Many people think that the true occurrence of absent ductus venosus with intrahepatic connection may actually be underdiagnosed, like not recognized in all patients, because again, in general, those patients do relatively well. If the absence of the ductus venosus is recognized early, for example, at 11 to 13 weeks of gestational age, there is an association with nuchal thickness in terms of the prognosis. So if there's an increased nuchal translucency as well as thickness and increased NT thickness, as well as the absent ductus venosus, it's more likely to be a poor prognosis, and probably more likely to be the extrahepatic connection as well. In terms of genetic associations, these can include aneuploidy, Turner syndrome, and Noonan syndrome. So here, this is a sagittal sweep of a fetus. The baby's head is up here. The baby's feet are down here. You can see the heart moving up here in the chest as we sweep. This is going to be the descending aorta posteriorly. And as we follow the umbilical venous return back towards the heart, where we would usually see the ductus venosus becoming this restrictive vessel with continuous flow, we lose that completely. And in this baby, on multiple sweeps through the entire fetus, as well as in the sagittal plane, as well as in the transverse plane, you just lost that flow within the liver. And you never saw a large vessel draining anywhere else. The baby did very well throughout gestation, never developed any evidence of high output heart failure or hydrops fetalis, and was born and had a very normal evaluation postnatally. This was a great diagram from an article in Prenatal Diagnosis demonstrating different connections. So here we have the umbilical vein connecting to the normal ductus venosus and then the right atrium. Here, this one, we see the umbilical vein draining directly into the IVC. So again, if you think the ductus venosus is absent, you need to do a very thorough evaluation of the IVC, the right atrium, all the other systemic veins connecting to the heart. In this picture down here, we see the umbilical vein coming here and draining almost directly into the right atrium. And so it's, in general, when there's an extra cardiac connection of this, it's, generally a pretty big vein and a lot of flow. So that's what you want to look for. Other signs, right? Secondary signs of abnormal volume load to the fetal heart. You want to be looking at chamber sizes, cardiothoracic ratio, your other measures of fetal well-being and fetal hemodynamics, your Dopplers, all of those things, as well as ventricular function, AV valve regurgitation, looking for all those things. And obviously, if you see any of them, you would be more worried. And then finally, if we do have these findings in fetal life, what do we need to think about doing postnatally? So again, I'm kind of not talking on purpose very much about heterotaxy because that's what Kareem will be educating us all about shortly. But in general, it is important for these patients to have, sorry, that was supposed to say postnatal transthoracic echo. You can see my brain was in fetal echo mode as I was writing this, and a peds cardiology consult. If there's no other significant concerning cardiology findings in the heart on fetal echo, this can be non-urgent. And sometimes it can be on an outpatient basis. You can wait for the postnatal transition to occur to decrease the likelihood that you're then going to have to follow a PDA or something like that. But in general, as we all know, there are limitations to fetal echo.
I think how long do you have?
This is the last slide.
Okay, great. Thank you. Yep. We're enjoying, but yep. I don't want Kareem to stay late. Thank you so much.
Yep. No, this is the last slide. So fetal echo and peds cardiology consult, just to make sure there were no minor abnormalities that were missed. For ductus venosus, absent ductus venosus, we do generally recommend an abdominal and liver ultrasound, and then genetics evaluation if indicated, if it wasn't done prenatally. And that is all. Thank you very much.
Thank you. Beautiful talk and really, really very a lot of information. Allow me to ask you two questions and part of my ignorance. Now, I like very much when you said left SVC is not a left SVC. Can you elaborate more on that, please? Antenatally and postnatally, yeah.
Yeah, so I think a lot of the time, when we see a venous vessel coursing through the thorax on fetal echo, our minds automatically will jump to an LSVC and assume that it is an LSVC. But I think we have to remember that the levoatrial cardinal vein or other venous abnormalities can also show an abnormal vein draining through the thorax. So looking at whether or not that vessel is anterior to the pulmonary artery or posterior to the pulmonary artery can be very important. If it's posterior to the pulmonary artery, recognizing that that's usually a levoatrial cardinal vein, and then you've got to go looking for why that's there. What was the reason for the left atrial outlet obstruction in fetal life that led to that persistence of the levoatrial cardinal vein? Is there total anomalous pulmonary venous return? Is there mitral stenosis? Is there small left-sided structures with some obstruction to the foramen flow to the right atrium? So I think, it's very easy to see a venous structure in the thorax and go, oh, I think that's a left SVC. But there are clinically important things that could be missed if you don't recognize that it's in a different location and it's not actually a left SVC, it's a levoatrial cardinal vein.
So the three vessel view for the left SVC would be as good as for the levocardinal vein, right?
Yes, and you want to look at where it is in the anterior posterior dimension. In the transverse view, if you have adequate images, you can often track it down to either the coronary sinus or see if that vein connects directly to the left atrium. Again, some left superior vena cavae can also connect directly to the left atrium, but looking at its course through that, making sure that it's not going down to a pulmonary venous confluence, and that's can often look like it's where the left atrium should be. And so, really good evaluation for where the pulmonary veins are connecting. Is that actually draining into the left atrium, or is it a pulmonary venous confluence? But, next to a small left atrium that is actually being then decompressed by a vertical vein or something else.
Very important. Norman, do you want to say something? I can see.
Yes, I do. First of all, I enjoyed that talk very much indeed. It was very clear and beautifully presented.
Thank you.
Thank you. I wanted to just make one point about levoatrial cardinal vein. We recently encountered and published a patient, I think it was in case, of a patient who had a left superior vena cava to coronary sinus and a levoatrial cardinal vein. And
wow.
I asked my mentor, Professor Anderson, about this, and he said, of course, the coronary sinus is much more an ownership of that cardinal vein, and the levoatrial cardinal vein is probably a misnomer. If you think about it and you look at this, I don't know whether you can see this in a fetus. I don't know that I've had this experience, but the levoatrial cardinal veins, according to the late Dr. Paul Weinberg, arises more of the origin of the left pulmonary veins than centrally, as it usually does in a total anomalous pulmonary venous return. And you made the point very clearly that the LSVC usually runs between the pulmonary veins and the left atrial appendage. That's its home site. And of course, in anomalous pulmonary veins, it may also run in that direction. And when it runs between the left pulmonary artery and the trachea, it can be obstructed and give rise to that, what you mentioned, the hemodynamic vice. So the anomaly of that structure in total veins may not be part of the left cardinal system. And in the patients that we've seen with left cardinal vein persistence, they drain into a variety of ways. They drain, as sometimes anomalous pulmonary venous return drains across into the azygos or the right superior vena cava, or into the left brachiocephalic vein. So it's a very complicated issue. I can't say that I have had that much experience with this in utero, but I think that you're right, that when you find a structure in the 3-vessel view and you cross it out and call it the 4-vessel view, you have to speculate on the origin of that vertical structure. And you can call it what it is, but it's probably not called the levoatrial cardinal vein, because it's not really part of the levoatrial of the left cardinal system. So that was the one thing. The other thing that,
but your case, Dr. Silverman, that had both the left SVC and levocardinal vein, because yes, what Sarah is saying, if you see levocardinal, think of that. If you see left SVC, think of small heart structure. So did this patient have both or nothing?
Yeah, my patient had both. It's published. You can just check it up on my name and find that publication. But I just wanted to make another interesting point I don't want to steal Karim's thunder, but there are differences in, and heterotaxy is a terrible term, in left and right atrial isomerism. When you get a right atrial isomerism, you actually basically have two right atria. So the superior vena cava drains directly into the roof of the right atrium. In left atrial isomerism, it generally, and you can look at this in many textbooks, etc., you'll see what looks like a valve. It's not really a valve. There's a persistence of the connection between the coronary sinus and the left atrium, the so-called coronary sinus septal defect. And you can see that, so that the two of them, although they both have bilateral superior vena cavas, are different from their drainage into the heart. That's all I've got to say, but it was a wonderful talk, and I hope these little things that I put up are useful.
I have a question that I asked you before, and I want to ask Sarah, because Sarah, you said 84% of patients of normal people, of a population will have with interrupted IVC, this is a heterotaxy. So 0.4% are normal with all congenital heart disease. So is that true that if you see an interrupted azygos, you call this as a heterotaxia or as a normal? Because I had someone counseled by geneticist, and when she saw the interrupted IVC, she said that this is a heterotaxia syndrome.
Yeah, that's a great question, and I'll be interested to hear what Karim has to say about that too. With it, we have a colleague join us about a year ago, Chris Jordan, who's a pediatric cardiologist who then did another fellowship in genetics too. So he has a very special interest in cardiogenetics and heterotaxy and genetic associations with that as well. I don't know that we know for sure. If you know, I think
well, you said it could be normal. You in your
traditionally most people would say it's heterotaxy because there's such the strong connection. However, if it truly is isolated and we have no other abnormalities, unless we really do have a good handle on whether there are specific genetic abnormalities that can be tied to certain types of heterotaxy and certain abnormalities, perhaps then we will have more answers. But I think for now, I would be cautious about labeling someone heterotaxy if interrupted IVC is really, truly the only abnormality, and there's no other extracardiac abnormalities like abnormalities of splenic function or other abnormalities that can be seen in heterotaxy syndrome. I think it's tough. It's not, I don't know that there's a clear answer. And Norm, I don't know what your answer was and if you agree with me on that or not. But
well, it's always advisable to agree with the expert panelists. So I do agree with you, but there are patients, and this is the pointed issue that you make, is you can't use just the azygos connection to make the diagnosis of left isomerism. So there are patients that are normal that actually, for one reason or another, don't have a superior vena cava, and also patients that have very large azygos system, well developed. Remember, the azygos vein is draining the lumbar region of the back. It's draining also the intercostals. That's that beautiful diagram that was written in 1954 by Frank Netter. It clearly still shows that the embryology is real there, certainly on the venous anatomy side of things. So the answer is that most of the patients with interrupted IVCs are heterotaxy, but don't use that as your diagnosis, because that's a failure of the morphologic method. And I'm sure that Karim was going to explain it, and if he doesn't explain it, I'll be glad to make a little comment after his talk.
Yeah, no, thanks.
I think we should move on.
And we do appreciate your presence.
I'm going to leave.
I hope your baby gets well soon. And thank you
so much. And
Karim,
sorry if I extended into your time, but thank you, everyone.
To see you. Great talk. Thank you so much.
Thank you. Good to see you too, Norm, and everybody else.
Thank you.
I'd like to introduce our next speaker. Karim is a colleague and friend, and he's also he's the director of the fetal program at Inova, but he's moving to Lori. and he's a consultant pediatric cardiologist with a lot of publications. And welcome, Karim. He's going to talk to us about the interesting topic of continue on heterotaxia syndrome and veins.
Thank you, Rima, again, and great to see you, Norm. Thanks, and
Thank
great
you,
to see
Karim.
you again.
Good to see you.
Yeah, it's always time, that we're getting back into in-person meetings. So, but I'm glad to see this continuing on a regular basis. It's really great. Of course, Norm is, great expert in heterotaxy, but so the main focus today is on the fetal heterotaxy syndromes and situs anomalies. No disclosures really to make. But what I'd like to do, I know Sarah already mentioned few cases or anomalies that are associated with situs, but we'll dig further into details into those. We'll go over some basic definitions just to make sure it's clear what kind of situs abnormalities we deal with in fetal cardiology, recognize the different types of heterotaxy syndromes, go over some of the basic views to determine situs and the various anomalies. Then we'll go over some of the associated cardiac as well as extracardiac anomalies. And we'll go over a bunch of case examples that hopefully the audience would like, just to get familiar with some of the lesions we see. And I'll go over some of the outcomes associated with heterotaxy. So to start off, just basic definitions. When we say situs, obviously that means the position of some of the body organs. When everything is normal, which obviously most of the population has, is what we call the normal situs or situs solitus. And, obviously some people grow right and left instead of left and right. And you can have a complete mirror image of the organ positions with what we call situs inversus totalis. Now, heterotaxy, as probably many of you already know, comes from a Greek. The Greek words heteros and taxis basically just means that a person has a different arrangement than usual. So it's different than situs solidus. It is different than situs inversus totalis. Sometimes we get fetal cases referred for situs inversus totalis, thinking there is a major cardiac lesion, but I'll go over that as well. So when talking about anatomic positions of different organs, we like to divide the body structures into four types. So we have structures that are mirror image of one another. Common examples: ears, eyes, our arms, legs, feet, and hands. Those are mirror image, right and left. There are body organs that are paired, but they're not mirror images, such as the kidneys, the lungs, and importantly, obviously, and we'll talk about that in more detail, the cardiac atria. And we have another subset of organs that are unpaired, and subsets of that are those that are in the midline. So we have one structure of each, like the trachea, the esophagus, mouth, or thyroid glands, and unpaired structures that are either right-sided or left-sided. And the important ones, the stomach, spleen, liver, and from a cardiac perspective, the aorta and the vena cava. So those are important structures to think about when you're thinking about situs positions and abnormalities. So what does qualify for a what we call a visceral heterotaxy that belongs to those type of syndromes that we're discussing today? So we either have two right lungs or two left lungs. You can have two right-shaped kidneys or two left-side kidneys. You can have spleens on both sides or no spleen at all. You can have a midline liver. The intestines might be malrotated, and you can have pancreatic agenesis. Of note, none of these really are associated with the position of the heart in the chest. So, not always you have a heart and dextrocardia with heterotaxy. We'll go over that. So when you're looking at heterotaxy, we look at three anatomical levels: the bronchopulmonary tree, the atria, the cardiac atria, and the abdominal organs, mainly the liver, stomach, and spleen. And again, we don't really focus on the position of the heart, whether it's in levocardia or dextrocardia, to determine if a patient has heterotaxy or not. And one important rule is, once one organ arrangement in one of these three anatomic locations usually reflects the other. So usually it kind of follows the same pattern. So moving forward to, talk about heterotaxy syndrome itself, it's a combination of different findings with mixed situs of paired, non-mirror and unpaired organs across the axis of the body. It's not very common, but not extremely rare either. We see at least a dozen of cases, all practices actually. I think if Grace is not with us, but we had a bunch in Doha as well. Sometimes I don't know if there's some risk, but we'll talk about it even from a genetic perspective. So incidence is about 1 in 20,000 is commonly noted. Some studies a little bit more frequent, but I think that's probably closer to that type of incidence. It does occur in about 4% of infants with congenital heart disease. And as we always like in medicine, we like to categorize things. And just to make it easier, we categorize it into two different syndromes, the asplenia or the right isomerism and the polysplenia or left isomerism syndromes, because there are certain associated lesions, which we will talk about, that are more characteristic of one versus the other. But keep in mind that there is a broad overlap of these horns. So it's not really a black and white picture all the time. Interestingly, in postnatal life, asplenia tends to be more common than polysplenia or left isomerism. But in fetal life, at least from several studies, it looks like polysplenia is more common, about 40% versus 30%. And this kind of leads us to think there might be a higher fetal or in utero death of these fetuses with polysplenia. And we'll talk about, outcomes a little bit later in the presentation. And, could be one reason we'll talk about that as well is heart block, which is obviously associated with high risk in these fetuses. In some studies, just looking at risk factors, in addition to genetics, the presence of maternal diabetes is also a risk factor. And hence, I think, obviously, it's one of the recommendations to screen the fetuses of pregnant moms with diabetes. To talk about the two different syndromes, so asplenia or right isomerism, you have no spleen, so obviously spleen is on the left. So the asplenia syndrome comes with no spleen, bilateral right-sidedness with bilateral trilobed lungs, and isomerism of the right atrial appendage on both sides. With polysplenia syndrome, we have what we call bilateral left-sidedness. Again, the spleen is on the left, just to help remember. Multiple spleens usually, although that does not, always mean that the spleens are functional. So you can have functional asplenia even if you have a polysplenia patient. We have bilateral or left bilobed lungs and isomerism of the left atrial appendages. This kind of slide just summarizes the different combinations. So obviously the normal or normal situs solitis, you have, the trilobe right lung and the liver on the right, and situs inversus totalis. You have complete mirror image presence of the right lung on the left and the left lung on the right side, with the liver on the left. And right isomerism, you have right-sided isomerism of the lungs. So you have two trilobed lungs, as you can see, and left isomerism, you have the bilobed lungs, and we'll talk about the other associated anomalies as well. So two major definitions, those that follow the Van Prague definition, which basically defines the atrial situs based on the connection of the IVC and coronary sinus. I'll be interested in knowing what Norm likes to follow with that definition. And then the Anderson's definition, which is defining the atrial situs based on the morphology of the atrial appendages, always not the easiest to tell on a fetal ultrasound. And then we end up with what we label normal situs solitis, or inversus or ambiguous with the Van Prague definition, and with the Anderson's definition, the usual normal situs, the situs inversus, and right and left atrial isomerism. So atrial heterotaxy, as I mentioned earlier, with different morphologies of the atrial appendages. With normal situs, you have the left atrial appendage that is finger-like, and the broad right atrial appendage with situs solutus. Everything is flipped right and left, so you have the broad-based right atrial appendage on the left and the finger-like atrial appendage on the right. With right isomerism, you have kind of two appendages on both sides that are of the right atrial morphology. They are broad, and then the left isomerism where you have the left atrial morphology on both appendages on both sides. So in medicine, obviously there are always right and left structures that can confuse us. And one common example is technicians taking X-rays, and it's obviously, if you remember, looking at the X-rays, the technician has to put the label to show you which side is the left side and which side is the right side. Otherwise, if the X-ray is left with no label, then if you flip the X-ray film, then you can't really tell which side is the left side of the patient and which side is, the right, whether the patient has dextrocardia or not. And similarly, in the fetus, unfortunately, the technician cannot go in and put a label. But if they show you this picture with a 4-chamber view, that you can't really tell, is this normal situs or situs inversus? By the way, one of these clips is with a fetus with a normal situs or situs solutus, and the other one is a situs inversus totalis. And so if you don't follow a certain way to tell which, what the situs looks like, it can be quite confusing. And so one easy method to follow is what's called the Cordis method that was published back in the 90s. Just for those, who do routine scans, I'm sure, a lot of people on here are familiar with this. So you put the, you take a sagittal view of the fetus with putting the head of the fetus on the right side of the screen, and then you just perform a 90-degree clockwise rotation to get the transverse view. And by doing so, you end up putting the head of the fetus towards the screen. You end up with one of the 4 presentations, with always the head of the fetus towards the screen, and you can end up with the spine being up or down or on the side. And then you can determine which left of the fetus is left and which side of the fetus is right. So with this is an example of a normal situs in a fetus, with the head to the right and just a clockwise rotation. The spine is backwards. So now we know that this is the left side here and this is the right side, and the stomach is on the left, the liver on the right, and the heart is in levocardia towards the left side of the chest. That's an example of a situs inversus. So same technique. Again, putting the head of the fetus to the right and then doing a clockwise rotation, 90 degrees, and then you end up with the spine being here. So this is left and this is right. And you can see here in this patient has a stomach on the right side, the heart is in dextrocardia, and the liver is left-sided. So again, if I only showed you the 4-chamber view, then you can't really tell from this patient whether this patient has normal situs or situs inversus totalis. So very important to follow a certain technique to determine which side of the fetus is left and which side is right, and where the organ location is. And why is that important from a pediatric cardiology perspective? Well, because situs is quite associated with the risk of congenital heart disease. So whether you have normal situs or abnormal situs, it's really dictates what kind of risk you have for congenital heart disease. So if you have normal situs solutus with levocardia, with a heart in the left side of the chest, the common incidence of congenital heart disease is about 1% in the general population. Now, if you have normal situs, you can still have dextrocardia with normal situs. And if that happens, then there is a high risk of congenital heart disease, more than 90% from various studies. Now, if you have abnormal situs, also the risk of congenital heart disease is changes. So if you have situs inversus totalis with dextrocardia, just like the case I showed, usually the coded incidence of congenital heart disease is similar to situs solutus with levocardia. Some studies have shown a little bit higher, 5 to 10%, but typically it's about 1% as well. Now things change if you have the opposite. So if you have situs inversus with levocardia, So just this is similar to situs solitis with dextrocardia, very high incidence of congenital heart disease. And if you have right isomerism or left isomerism, then again, very high risk for congenital heart disease, more so with right isomerism than left isomerism. We'll talk about that as well. So hence the importance of determining situs and looking at these structures from a cardiology perspective as well. So again, situs solitis with levocardia, just like the case I presented earlier. So this is just normal. And again, incidence of congenital heart disease about 1% in the general population. Situs inversus totalis, which we talked about, actually was described back in the 18th century during a anatomy class. So the students were actually dissecting a cadaver, and it turned out that the organs are flipped completely the opposite side. So it was Dr. Bailey who sent a letter about it in London. And the incidence is quite low as well. It's about 1 in 25,000 live birth. It is autosomal recessive, so if it happens in a family, there is a risk for future babies to have it as well. Again, congenital heart disease, less than 10%. Most studies point to, about similar to situs solitis with levocardia. High association with Cartaginer syndrome or ciliary dyskinesia syndrome, which is obviously associated with chronic respiratory infections, as well as ear infections and infertility. And importantly, those with Cartaginer syndrome, about 50% of them have situs inversus totalis as well. Now, with heterotaxy, if you have right or left isomerism, I think we all have played Lego back in the day. So if you don't put your Lego blocks correctly, your tower just falls apart. And similarly, the body with heterotaxy doesn't function very well, and we end up with higher chances of complex lesions, which we will talk about. Before we go into the different lesions, wanted to just say just a word about the genetics in heterotaxy syndrome. Usually, most of these cases will have a normal karyotype. There has been very few case reports of Turner syndrome, trisomies, as well as the George syndrome, but these are not really common. There is, again, as I mentioned earlier, about 10% recurrence rate in future pregnancies. There has been some genes implicated in the embryology, particularly the ZIC3 gene that actually sometimes comes on the American board for those, taking that. So that's a gene involved in the embryological development of the fetus and with right and left patterning in the fetus. Now, that being said, what are really the cardiac findings in heterotaxy, particularly with the right isomerism and the left isomerism cases? As you see here on top, the dextrocardia doesn't happen all the time, and it is common in both right and left-sided isomerism. So about 40% of the cases in either one. Bilateral SPC that Sarah just went over in details can happen in both. Absent coronary sinus is quite common, more so in right isomerism compared to left isomerism. IVC interruption is a hallmark of left isomerism. I think, at the end of the previous talk, there was a question of is it only present with left isomerism? I don't think so, but extremely rare without left isomerism, extremely rare. So really you have to suspect polysplenia if you do have that. Extremely rare with right isomerism, although has been described as well. Juxtaposed aorta and IVC, meaning the aorta and the IVC are on the same side, and this is a hallmark of right isomerism and extremely uncommon with left isomerism. So these are very differentiating findings. The presence of a common atrium, we'll see some examples, can happen in both, more prominent in right isomerism. Total anomalous pulmonary venous return and venous anomalies, more common with right isomerism, very rare with left isomerism. And the most common cardiac defects, really just kind of at the end of that slide, is AV canal defect, which happens more so with right isomerism, but is the most common cardiac lesion in heterotaxy of either type. Very important is looking at, whether cardiac lesions in either form of the syndrome tend to be single ventricles versus biventricular lesions. And this is an important differentiating factor. So right isomerism is more associated with single ventricular physiology, while left isomerism, most of the time, it results in biventricular physiology. The ventricular arterial connections are mostly discordant with right isomerism, and they're mostly concordant with left isomerism. Dwarf is a common lesion that we see with right isomerism compared to polysplenia. Again, D and left transposition of the great arteries, way more common with right isomerism, while mostly the great arteries are normally related with left isomerism. Right isomerism, again, just as the name implies, right is usually associated with high incidence of right-sided obstructive lesions, about 90%, which are much less common with left isomerism. Left-sided obstructive lesions are more common with left isomerism, not as common though as the right-sided obstructive lesions that we see with right isomerism. And another hallmark of left isomerism is a heart block of different various degrees, and we'll go over that as well, or even just sinus bradycardia. So very common with left isomerism, extremely rare to see with right isomerism. How about the extracardiac defects? Intestinal malrotation is usually present in either form of the syndrome. There are additional extracardiac anomalies, more so common in left isomerism compared to asplenia, and these can include biliary abnormalities, duodenal atresia, urinary anomalies, and again, those are way more common with left isomerism than in right isomerism. So going back to imaging, as we went over, very important to determine situs, because that can really direct you to where things sit and what you need to look out for. And we always start after determining situs, start the scan from the upper abdomen, assess the position of the aorta and the IVC, and we'll go into details into that, and look at the liver and stomach, and then determine the connection of the IVC to the cardiac structures. And of course, we always follow the segmental approach, and of course, then we determine the position of the systemic and pulmonary veins and the atrioventricular connection and the ventricular arterial connections as well. So just to, again, re-emphasize the normal to recognize what is abnormal. So you can see here the patient with situs solitalis, you can see the spine is here. This is left side, this is right side. Obviously, we're not showing the situs sweep here, but you can see the aorta is anterior to the spine, and anterior to the aorta is the IVC on the opposite side. So this is very important. And the stomach here on the left, again, the stomach can be anywhere, so it's not really reliable to look at it. And then we trace the entrance of the IVC into the right atrium. In situs inversus totalis, which I showed the clip earlier, things are reversed. So again, you can't really just look at the transverse view, but once you have determined that there is situs inversus totalis, important to look at the abdominal cut, to look at the position of the various structures. So in this case, you can see here the spine on the back. So the aorta and IVC are still opposite to one another, but the aorta would be on the right, the IVC on the left. And the stomach, typically with situs inversus totalis, is on the right, and the liver on the left. In asplenia syndrome, there is what we call a juxtaposition, which I talked about earlier of the aorta and the IVC. All what that means is they're on the same side instead of being on the opposite side. And as you can see, these are two examples. So they can be on the right side of the patient or on the left side of the patient. There are two big vessels here. The aorta is still posterior to the IVC, and we'll see why that is important. Again, the stomach is not a reliable structure to look at where it is located when you're dealing with heterotaxy. This is again just to give you some clues. When you find that there's some abnormal organ position, so clues for right isomerism or asplenia syndrome is again the aorta is behind the IVC on the same side. So there's juxtaposition compared to the normal situs. The stomach is again not reliable. presence of certain cardiac lesions, as I mentioned earlier, single ventricle, total anomalous pulmonary venous return, or RV outflow tract obstructions or right-sided obstructive lesions. And a common finding is what we call the common atrium, with what we see a central dot sign, which I'll show some examples as well. In polysplenia, on the other hand, the abdominal view is very important as well. It's usually because of the interruption of the IVC. You'll see that there are two vessels, but unlike in asplenia, these two vessels are different. The IVC, you cannot see it, but what you'll see is the descending aorta and the azygous vein due to the continuation of the interrupted IVC through the azygous or hemiazygous. And the way to differentiate is obviously the aorta here is pulsatile, so you can tell which one is an artery, which one is a vein. And unlike in asplenia, where the IVC is still anterior to the aorta here is anterior and the azygous vein is posterior. So again, hallmark and clues to left isomerism, the presence of IVC interruption. You see two large vessels in front of the spine on the same side, with the aorta being more anterior, unlike in asplenia, where the aorta is posterior to the IVC. Stomach, again, is not reliable. And another really important clue, doesn't happen in all the cases, but very important clue is the presence of bradycardia and heart block, which is way more common left isomerism, extremely uncommon in patients with right isomerism or asplenia. So to go over a few cases, this is the case of left isomerism. You can see here the two large vessels with the aorta being anterior, posterior azygous, and this patient had AV canal as well. That patient had levocardia in this one. Here's the view of the azygous continuation. So once you go to the long axis view of the fetus, you'll see two vessels running parallel to one another. You can tell one is pulsatile and one is not. So very important to determine, Doppler these vessels and show that one is actually pulsatile, this is the aorta, and the posterior vessel is the venous structure. So you can see the venous Doppler as well. Here's another example of isomerism. Here you can see this is the sweep from the sagittal, from the transverse abdominal view. So you can see the spine, and you can see these two vessels, one posterior to the other. This is the aorta, and this is the azygous behind it. And this patient had the stomach on the left with the heart in dextrocardia with the apex to the right. And this patient also had a complete AV canal as well. Here's another example just showing that parallel vessel of the course of the azygous posterior to the aorta, as we saw in a previous picture. This is again just to compare the normal to patients with interrupted IVC. So here's the normal bicaval view, and here you can see in a patient with polysplenia, interrupted IVC, and direct entry of the hepatics into the right atrium. In left isomerism, again, as I mentioned, there is a significant incidence of bradycardia and heart block. So again, in this case, you can see that the heart is beating a bit slow. Heart rate in this case was in the low 60s. And another thing that Norm usually highlights in left isomerism is possible presence of non-compaction, which sometimes we see as well. So it's an important finding, obviously can result in dysfunction that can affect the outcome in these patients as well. Here's a case of left isomerism. You can see here complete AV canal. It's almost a common atrium as well. You can have AV canal of different sorts with heterotaxy. This is a case of complete common AV canal with a large primary MASD, large secondary MASD in this case as well, and the large inlet VSD with a balanced canal with balanced RV and LV sizes. Here's another example of right isomerism case or asplenia. You can see here large primary ASD, common AV valve, and an inlet VSD with what looks more of a balanced AV canal. Like you can have balanced AV canal, you can also have unbalanced AV canal. I'm not sure if there has been any description of, the presence of unbalanced AV canal with either asplenia or prosplenia syndromes and the incidence of each, but that can definitely happen in either one. In this case, you can see the left ventricle being smallish with the valve opening mostly into the right ventricle and a RV dominant, right-sided dominant AV canal. Here's another example of right isomerism. This patient had, again, what we call the common atrium. You can see the dot sign, which I mentioned earlier. Common atrium seems balanced, just a little bit dilated right ventricle. Also had dwarf with both great arteries coming off from the right ventricle and with the aorta detransposed, meaning it's more anterior and rightward compared to the pulmonary artery. Here's another case. You can even tell from this picture, there is an overriding aorta. This patient had tetralogy. There was pulmonary atresia. The ductus was reversed. You can see here, this is the long axis view of the arch, and you can see the ductal flow being reversed. This patient had TET, AV canal, and pulmonary atresia with reversal of the ductal flow as well. Here's another example of right isomerism with dwarf, two great arteries coming off from the right with detransposition. Again, the aorta is coming off rightward and anterior compared to the pulmonary artery as well. As I mentioned earlier, important to look at the pulmonary veins. Here's actually a recent case that we had, and here at Innova, and you can see this is what we suspect, the right isomerism. Actually, the baby is still not born. You can see complete AV canal, and when zooming in on this picture, you can see, again, that's primary ASD, the common complete AV canal. There is one big great artery, which we think is there's pulmonary atresia. An important view from from the veins perspective, looking at the gap between the aorta and the left atrium. You don't see any pulmonary veins coming into the left atrium. So again, with right isomerism, important to rule out total anomalous pulmonary venous return. You can see very abnormal flow of the pulmonary veins in this patient, which with what looks like a vertical vein and likely to be a diaphragmatic total anomalous pulmonary venous return. So again, this is more likely to be seen with right isomerism than left isomerism. So that being said, looking at outcomes fetally and postnatally in these patients, and I'll present some of the studies, the major studies that have been published out there. So this is the major study from Sick Kids from Toronto, and they had compared their prenatal and postnatal diagnoses of both syndromes. They had about 69 patients with right isomerism. This was published back in 2005. About 100 left isomerism cases, about half prenatally diagnosed versus postnatally diagnosed. Obviously, we hope that we can catch most of these cases now prenatally, because they usually have very abnormal findings. So, we really count on OB and MFM to detect them and refer them for further evaluation. We'll talk about that as well. So this is the survival of these cases from Sick Kids. The 5-year survival for those patients with left isomerism was about 75% versus a little bit short of 30%, and those patients with right isomerism. Most cases of left isomerism needed no intervention or had biventricular repair, unlike right isomerism cases, which mostly had a univentricular repair. So to compare the two, there was an increased risk for in utero demise in this series, mostly due to high degree AV block. There was significant impact of the presence of non-cardiac defects on the outcome, and they noticed a less severe cardiac abnormality in those patients with left isomerism versus right isomerism. And a better postnatal survival rate in left isomerism compared to right isomerism. However, again, in this series at least, the prenatal diagnosis did not really make a difference on the postnatal outcome of these cases. This is the another study from Boston, was published in 2014. They went over about a little bit less than 10 years worth of their experience with heterotaxy, with a total of 154 fetuses with heterotaxy, about half, and with asplenia versus polysplenia. There was significant fetal demise or termination of pregnancy, particularly in the asplenia series. Their 5-year survival with asplenia syndrome was about 53%. Very few had biventricular repair, about 8%, while the 5-year survival in those with polysplenia was about 86%. However, most of those had biventricular circulation in about 65%. Bradycardia was again noted to be a significant risk factor for fetal demise, and pulmonary venous stenosis and the presence of extracardiac anomalies were found to be independent risk factors for postnatal death. You can see here the survival in their series and the significant difference between those with polysplenia versus asplenia. This is at 5 years. The univariate risk factors for mortality included mainly total anomalous pulmonary venous return, pulmonary vein stenosis, as well as non-cardiac anomalies that really affected the outcome in these patients. This is to highlight the importance of the presence of heart block or bradycardia in the setting of heterotaxy. So again, the presence of either sinus bradycardia or, more importantly, of course, advanced AV block and the risk for hydrops in these patients, with obviously severe, risk factor for fetal demise or even postnatal death in these cases. So this is an important finding for prognostication and counseling of these cases. The risk factors for postnatal death included the presence of hydrops, of course, in babies who are born premature, bradycardia again with ventricular rate less than 55, as well as cardiac dysfunction, as I mentioned, in the left isomerism. Keep an eye out on any presence of hypertrabeculation or non-compaction of the ventricles. This is a more recent meta-analysis that was published just a few years ago. Again, just highlighted the main findings, the cardiac findings in either syndrome. So with the most common diagnosis is again AV canal, which happens in most of the cases, 60 to 70% in either left or right isomerism. And the lesions that are most associated with right isomerism are in yellow here. You can see, as I mentioned earlier, single ventricle physiology, right-sided obstructive lesions, conotruncal anomalies. These are and total anomalous pulmonary venous return. On the other hand, interrupted IVC in the presence of arrhythmias are the characteristic of left isomerism cases. Here again, their table summarizes from various studies looking at the prevalence of arrhythmia, and you can see much higher prevalence of that, whether it's AV block, first, second, or third degree, or just sinus bradycardia as well. More significant in left isomerism than in right isomerism. Quite unlikely to see that with right isomerism. The outcome from surgeries, again, in left isomerism, most of the patients from various series and the meta-analysis mostly received biventricular repair in left isomerism. Very few received that in right isomerism. And obviously, in conjunction, the right isomerism cases mostly had a univentricular type of repair. The mortality rate from surgical intervention during or after surgery was almost a quarter of the patients in either side. Even if you look at transplantation in patients with heterotaxy, this is actually a paper that came out of Cincinnati that is just accepted, so it's actually in publication or in press. Even the outcome of heterotaxy patients receiving cardiac transplantation is much poorer than the results of transplant in patients that receive transplantation for other reasons, namely congenital heart disease or cardiomyopathy. So again, big center that performs over 4,000 cases of first-time heart transplants. Looking at that, interestingly, the incidence of acute rejection was similar in all cases, but the long-term survival in these patients is still poor. So in summary, heterotaxy is, again, not extremely common, but definitely there are different syndromes. Incidence is about 1 in 20,000. Always check the situs from a cardiology perspective is very important, and whether associated levocardia or dextrocardia, because that really reflects the risk for congenital heart disease in these cases. Try to define the anatomy because that will really determine the prognosis. Refer early to the pediatric cardiologist, of course, for proper counseling. Although I mentioned that you're really diagnosing prenatally doesn't change really the outcome much, but it is important, of course, for potential intervention in cases that an intervention is planned, as well as for proper counseling and expectation for the family. Unfortunately, the outcomes for single ventricles, again, those are usually most likely in right isomerism, are still worse in series from various major institutions compared to even hypoplastic left heart syndrome outcomes. Your best case scenario, if one would say, what is the best case scenario if you have a fetus with heterotaxy, is just to have polysplenia with interrupted IVC and nothing else. And again, this was, came up just earlier as a question. You mentioned that these have heterotaxy or not. Very handful of cases that have been described with no heterotaxy, but really polysplenia. But with interrupted IVC, I mean. But that's your best case scenario. You still have to check for extra cardiac anomaly. So even if you have no major cardiac anomaly, make sure that there is no intestinal malrotation, which usually happens in almost 100% of the cases. The worst case scenario is, again, the asplenia, a fetus with asplenia, dwarf unbalanced AV canal, pulmonary atresia, with small PAs and total anomalous pulmonary venous return, just like the case I showed. Extremely poor prognosis, probably survival less than 20% of that. So with that, hopefully we'll see you next time from Chicago. And I think we have some time, maybe Rima, for some questions.
Sure. Thank you so much, Karim. As usual, very, very detailed and up to date. Thank you so much. One question to you before we open the floor. I wonder, why would the long-term with the post-transplantation for the heterotaxia was worse?
Yeah, that's a good question. So, they had poor survival. I can go back to that slide just to show the actual numbers, and you can see here even immediately. So, besides the first year post transplant, the acute rejection rate was similar to other cases. So there was not really a problem with acute rejection, but it was mostly just failure post-rejection for various reasons. There was no specific, diagnosis that kind of led for the poor prognosis in this series, at least. But their overall survival was poor.
Maybe because of the extracardiac anomalies rather than
yes,
because
so
the heart is gone,
right.
You don't have maybe the connections, the tubes, but and also the worst case scenario you were saying, I mean, I would just add to what you said is that with heterotaxia, very unlikely to have genetic abnormalities. Do you agree to that?
Yes, correct.
And also
mostly,
and also
mostly microarray and karyotype usually normal. Very few rare case reports of some trisomies that we have seen.
We've done also a study, me and Norm at Stanford, regarding the non-compaction in utero. So heterotaxia with non-compaction was very poor, as you also said, and this is very important. And I was always told, if you want to choose which isomerism you want to get the left rather than the right.
Yeah, if you choose, except that, we've got the things that go on that aren't followed is the complete heart block that occurs with the left isomerism is a risk factor for all of life. the right isomerisms have, of course, because of their lack of splenic function, don't have a capsular antibody to protect them against Haemophilus, pneumococcus, and Neisseria infections. So you have to keep them on antibiotics for a long period of time, perhaps even throughout life. And I think that the heart transplant is going to be a complex issue. It's not like, you can just leave a little piece of the atrium behind, but you have to connect the venous or correct the venous anomalies as well. So there's a huge problem in terms of doing heterotaxy heart transplant. It's not a simple structure like taking a heart from a cardiomyopathy patient out and placing in a new heart using the venous, pulmonary venous and systemic venous structures. You have to really do all kinds of building. So I think it's more complicated heart transplant. And usually, certainly when I worked at Stanford, they used the guy who was the most expert at congenital and transplant to do the transplant because of these problems.
Thank you so much.
I want to make a few comments, if I may, Karim.
Sure.
I enjoyed your talk a lot. You're like a brother for me in terms of your thoughts on this project. But I want to point out to the audience over here that I think that the syndromes of left isomerism and right isomerism are completely different. I think they have a lot of overlap in the middle. And I think that the problem that you've highlighted, and you mentioned this in your talk as well, is that the isomerisms segregate out into left isomerism and right isomerism. And there was recently a paper by Steve Sanders and Tal Gaver, an editorial to a paper, which I'm going to show you in a few minutes, which says that we're going to have to drop this polysplenia and asplenia syndrome issue. And I think that it's important that we consider that these are two separate entities that all fall under the umbrella of heterotaxy, which is not a very good term. But I think that you should think of them, as you have done in the latter part of your talk, as left isomerism and right isomerism. And I think that's very important. And your point that you made, and I wonder whether you'd let me share my screen for a minute. Let me do this. Can I? Okay. Yes, I want to continue. Okay. So I want this over here. And I want to bring to your attention this paper. Oh, gosh, that's the wrong one. Let me just... It's a paper by Diane Yim. Here it is. This is a paper published recently from the group in Toronto, where they looked at MRI in patients with left isomerism and right isomerism after birth. And what they found was in about 20% of cases, the segregation was not complete. In other words, the left isomerism should have two bronchi and two left atrial appendages and multiple spleens on both sides of the dorsal mesogastrium. And these are probably the most important issues. And they found a 20% disparity. Here is the paper for you. And I think that if you haven't read this paper, you can't go forward with the understanding of heterotaxy. And in the same issue, there's cardiac imaging, there's a paper by Dr. Sanders and Tal Gaver on heterotaxy and the genetic basis of this disease. And it's clear that there are two different genetic bases. And I put this up from a paper that I have written showing a fetus with a knockout of his PTX2 gene and the production of right isomerism. So there are two morphologically right atrial appendages in this case. And the feature that's important here is this terminal crest or crista terminalis is present as bilateral structures. And I think that Professor Anderson and the papers in the Congenital Heart Academy archive, which you can now access, will show that that you can recognize this in the fetus as well. It's the usual bright dot in the atriums, and in bilateral right atrial isomerism, which is of the appendages, there are two little bright dots in each side. And of course, shape is less important, but this pectinate distribution is most important. Now, if you have a lefty knockout and you knock out the lefty, then all of the Pitex tunes go out this way. So this is a knockout Pitex 2 mouse, and this is a knockout lefty mouse. So it allows Pitex 2 to go over and express on the left side, and it expresses both of these as left-sided. So you get bilateral left atrial appendage morphology. Now, I don't want to leave you to believe that the genetics of this are simple black and white one gene. It's probably multiple genes and many things that we still don't understand about heterotaxy. But it begins very early in embryonic life. And so I think it's important that we can look at not only the morphology of the atrial appendages, which are here, bilateral finger-like atrial appendages, or this where it's broad-based and the appendage musculature heralded by the terminal crests comes out to be important. So the only thing that I would say now is to you is that you should read the papers from Professor Anderson and myself on the genetic influences of lateralization and polysplenia isomerism, and I'll stop my share and get back.
I think it's very important, Norm, what you said about the genetics, but let's not be confused. What is the message here? Are we going to use the atrial appendages, or what are we going to use now?
Well,
with the heterotaxy? I mean, when we were studying, they told us left isomerism, right isomerism, and then they said heterotaxy syndrome. And now what are we going to? I believe you, because there's nothing in medicine which is 100%.
Well, that's true, but I mean, I think that the thinking of this as an isomerism, and certainly the Yim paper shows that you know, there is a 20% error, but the most common features are the bronchial anatomy and the atrial appendage anatomy. And I just want to show you an example here that when you have bilateral, can you see this? Oh, I need to share this again. Sorry.
You need to share it.
Share the screen here. This is work from Dr. C.R. Patel and here I've got this, and he's shown the position of the pulmonary arteries with the epiarterial bronchi bilaterally, and you can recognize bronchial anatomy in the fetus. And the way to recognize it, just let me go through this quickly, is you can see that there's bilateral pulmonary arterial system. And then there is also, when you use color flow on this, and I think that this is important for the fellows here, is you can see now the fluid moving in and out of the bronchus, and the fetus is breathing here. You can see both these are epiarterial above the pulmonary artery, as you see it here, and you can see that the fetus is breathing fairly readily, but not at the rate that the heart is going. So you can now recognize the second thing that's important, which is the broncho-pulmonary arterial relationships in both this form of isomerism and indeed in this form of isomerism where the bronchi are bilaterally underneath the pulmonary arteries. And here's the bronchus lying underneath the pulmonary arteries. So I think that and the appendage morphology is really critical in terms of making their diagnosis. And it's available on the website through the YouTube channel to look at these again. And in case you think that you can't see these appendages, here is a patient with right isomerism which we published, courtesy of Julia Solomon, who's the lead author, and showing in this heart that not only are the appendages fairly symmetrical, but that you can identify the terminal crests in the anatomy as well. So that's all I have to say, and I'll turn it back to you, Rima.
Thank you so much, Norm. Where are we supposed to read this on the Congenital Heart Academy on the series from Dr. Anderson, or from where?
Well, the things are on the Congenital Heart Academy under my name, where there's an ecomorphological correlation.
Oh, okay, on your beautiful series. Yes, of course. Yes, of course. Yes, of course. Thank you so much.
I think also that these two events to show the appendage morphology and the precision of the terminal crest, because the appendages will not necessarily always be the same because of flow abnormality. So if you've got more flow to one of the atria or the other, that atria may be bigger and looks a little distorted from the other one. So you've got to go to the fundamental of this condition. And Dr. Van Praag, who originally said, you cannot look at the secondary characteristics to describe the primary abnormality in the disease. And the primary abnormality in this disease is probably the terminal crests that you can see in the appendages. So if you have no terminal crests, you probably got right isomerism, left isomerism. And if you've got two terminal crests, you probably got right isomerism.
Should we do, from what you said on genetics and the knockout gene, should we do West on every child with heterotaxia or a fetus on with heterotaxia?
Yes, of course. Otherwise, how are we going to recognize it? And the other point that I think Karim made that I want to emphasize is that although there's overlap, there's also segregation. I mean, for example, the interrupted IVC, 90%. If you find an interrupted IVC, that's your figure, Karim. I think it's Escobar-Diaz that said that. But if you find an interruption of the IVC, think isomerism Stradov and all of the things that occur in left isomerism, and then you'll get a much better segregation. Or if you find, for example, that you have bilateral right bronchi, think isomerism. And if you see juxtaposition of the aorta and the IVC on the same side of the spine, think right isomerism. Think of the list of the lesions, tick them off, and you will segregate those lesions out as a fetal cardiologist.
I want to add one more thing regarding the genetics. Karim, you kindly said that the recurrence risk is about 10%. There are also familial heterotaxy syndromes. If we go by, for the AMEM, and we can find different patterns of inheritance as well. So I came across one family as well.
Well, ZIC3, for example, is an anomaly that's been written up by Jeff Tobin, and that's a sex-linked gene. So there's genes on the Y chromosome that are responsible for heterotaxy. And I think the problem with heterotaxy that we don't understand is that it's probably a multiple genetic abnormality. For example, as Karim had so beautifully described, you see this anomaly in conditions within families, and it's not just a single gene anomaly; it's often multiple gene anomalies. And unless we give the geneticist the primary abnormality to look at, we're not going to get to the bottom of this genetics thing. If you look at, he was looking at this familial thing in the Cartagena syndrome, which is now called, what's it called? The Cartagena syndrome. Yeah,
dyskinesia syndrome, celiac dyskinesia syndrome.
But 50% of those patients don't have normal anatomy either. I mean, they have situs inversus, but many of them have congenitally corrected transposition and pulmonary atresia and down the list and AV septal defects. So we know that there are at least 12 genes that are involved in cilial motion. And this cilial motion is set up on the embryonic disc. So this is how early it is that the action is coming. And the cells that migrate through the primitive cleft, the primitive streak. Those cells are programmed to go a certain way from cilial motion that sets up the stream left to right side. So this is a very early phenomenon in embryology, that we've really not come to, but it's certainly fascinating to think about how these genes are set up to cause the cilia on the primitive streak to blow the fluid in the embryo from right side to left side.
The question to answer, Norm, is if you have an IVF and if you have same-sex fetuses, and in the audience we have also MFMs, are you going, and there is a heterotaxy in one, do you expect the heterotaxy to be in the other one?
It depends. I mean, yes, if it's genetic, you would suspect that it would be.
Yeah. Okay, thank you so much. Karim, do you have any
comments? One last question. I'm actually curious to know. So, I don't know if you like this dot sign or, when we deal with this common atrium. From your experience, do you think it is more particular to one or the other? I know it's more of an imaging sign than really looking at the appendages, I understand, but
which one are you talking about?
The common atrium
sign,
where you just see one bright spot in the middle of the atrium. Have you seen that more common with one versus the other isomerism syndromes?
Well, yes, I think it's always that when you deal a common atrium, the more common it's going to be, the same as with an AV canal, much more with right isomerism than with left isomerism. But you can't use that as a differentiation.
Yeah, no, of course, right.
The problem is, and that's again the same thing about talking about polysplenia and asplenia, and even Dr. Sanders and Dr. Taver have said we need to look for another term because these terms are inadequate. Because there are many patients in the YIM study that I put up for you that show that there is an absent spleen in left isomerism and multiple spleens in right isomerism. So there's, it's a complex thing to think of it simply as we take an experiment and knock out a gene and get something that determines the entire basis of which is left and right is a little bit simple in its understanding. So
beautiful
I think it's a much more complex issue.
Thank you so much for updating us. Karim, do you have anything to say?
No, thank you so much. This was really great. Happy to see you guys again. Thanks, Norm, for joining. That was a great input.
Well, thank you. And I really think you have a super perception, but only one thing, Karim, I want you to stop talking about polysplenia and asplenia.
We wanted to thank
that way when
everyone.
Professor Anderson comes to your new hospital, he won't try and kill you.
Well, I think we have to end now. We wanted to thank Sarah Chambers for a beautiful talk as well, and Karim, and we want to thank Innova Hospital for their contribution today. We'd like to thank Dr. Silverman and all our audience who actually they stayed very late, and hopefully we see them next month. And thank you again.
Yes, good. Okay, thanks. All right.